Let me ask you something. Have you been on menopause hormone therapy for months, maybe even years? Your doctor says you're on an adequate and standard dose and tells you to let's just monitor and see how you feel. But here's the thing, you still don't feel like yourself. Brain fog, waking up at 3 a.m., energy crashes, low mood. Your libido is nowhere to be found. And that weight around the middle, it just won't shift. Sound familiar? If you've ever wondered why your menopause hormone therapy isn't working the way you hoped, or if there's more you could be doing to optimize your hormone therapy, this episode is for you. Welcome back to Pleasure in the Pause, the podcast dedicated to empowering midlife women to connect to their bodies, pleasure and power in perimenopause, menopause, and beyond. I am your host, Gabriella Espinosa, and it is my pleasure to be here with you. Today, we're diving into a topic that's been requested by our community: how to actually optimize your hormone therapy when you feel it's not working. I'm thrilled to be joined by Dr. Jila Senemar, a board-certified OB-GYN with over 20 years of experience who has become one of the leading voices in menopause optimization. Dr. Jila is the founder of Jila MD, a concierge practice in Miami that focuses on personalized hormone therapy, metabolic optimization, and longevity science. She's also the founder of the Miami Menopause Collective, where she collaborates with women to create truly individualized treatment plans. What sets Dr. Jila apart is her personalized approach to hormone therapy as part of a complete optimization strategy, not just managing symptoms, but helping women thrive in their second half of life. Today, we're going to cover everything you need to know about getting the most out of your hormone therapy. Whether you're just starting to consider hormone therapy, you've been on it for years but aren't getting the results you want, or you're simply curious about what optimal really looks like, this conversation will give you the knowledge and confidence to take charge of your hormonal health. Let's dive in with Dr. Jila Senemar. Welcome, Dr. Jila.
Thank you for having me, Gabriella.
I am so excited for our conversation. Dr. Jila, you've dedicated over 20 years to women's health. What initially drew you to specialize in menopause and hormone therapy?
I have to say, this has been an evolving field. And us as women in this generation we're all going through it, we're all feeling it. And knowing that there's something more to it than just it is what it is and you just have to move on with it just didn't sit well with me. I knew there had to be more to it. And so just did more research into it, more for myself personally, as well as for my patients, because I just knew there had to be more than just, no, we don't give hormones. You will be okay. Just kind of, struggle and suffer in silence situation. That just wasn't appropriate answers anymore. And the more I looked and the more research I did and the more at the data I looked, I realized, yes, this is not new. This has been going on. There's a whole society behind this. And so, yes, we need to learn more. We need to self-educate more. And just starting that, I realized how much information we were missing and how women were just being dismissed left and right. I couldn't get the help I needed. So if I'm in the field and I couldn't find someone to help me, what was happening with everybody else? And
Mm.
that's where I decided, you know what? We need to know more. We need to educate the women so that way they can get the help that they deserve. Based on that, it came full circle for me where I realized I really want to focus on this subset of women. I've taken care of them for 20 plus years through their reproductive year, having their children and raising, having families and things like that. But why are we letting them down in this critical phase of their midlife? This is not an ending. It's, as we all know, this is a new beginning. This is a reinvention, kind of like, rediscovering yourself going forward into the next chapter of your life. And so I've met a lot of inspiring women along the way, such as yourself. And that's where my mind went. I'm like, no, I need to do more. I'm not done. There's a lot more to be said, a lot more women to take care of. And get this information out to them. So that's like how my journey began and where it's going towards.
Mhm, mhm. And what I love about your approach is that it's part of a very personalized and complete optimization strategy. It's not just about managing symptoms, but it's really about helping women thrive in the second half of life. Thank you so much for the work that you do. When women first come to see you seeking hormone therapy, what are they typically experiencing, and what realistic expectations do you set about what HRT can and cannot address?
So a lot of the women that I see on a daily basis in my offices is that a lot of them now are well versed in the realm of perimenopause and menopause. They're noticing the symptoms. They're able to pinpoint what's happening, even if they're not skipping their periods and they're not just having a hot flash. They are realizing it's bigger than that. So they're tuning into themselves and they come in and they're like, okay, so I'm having hot flashes. I am upset with my family all the time. I'm yelling at everybody and I don't want to be that person. I'm definitely not sleeping well and I'm tired all the time. And all of this is affecting my relationship with my partner or my husband. So they really want to get to the bottom of it. Nobody wants to put a band-aid over the problem. They want to know what's happening to me. How can I improve this? And is it diet? Is it lifestyle modification? Is it supplementation? Is it hormones? And how does it all play into one another? I do an extensive overall look at the patient. Like you said, we take a very holistic, total approach because it's not just the reproductive area that's being affected anymore. That area, we know estrogen receptors are all over our bodies. Progesterone, testosterone, they all play a role. It's not just one or the other. It's a nice combination of all of the above. And each person's symptoms are different. That's why it has to be so precision like, personalized to each individual. And there needs to be a lot of hand holding going forward. This is
Mm,
not, I don't believe in number one, a 5 or a 10-minute visit. My visits are over 30 minutes per patient. And some are up to like over an hour. I give them the time they need to just really get to the bottom of what's happening. Then we do extensive testing to double check everything else because, as we know, a lot of the symptoms of perimenopause and menopause can be seen in other issues, other endocrine systems. You could be a thyroid problem. You could have iron deficiency that gives you chronic fatigue and just not feeling well. So I have to double check everything before just kind of, writing it off based on hormones and saying that's what it is. And then once we get through all of that, the expectations are really important to set. I don't want them to think this is a magic pill. This isn't going to fix things overnight. And I think one of the biggest things to set for them is the weight component, because yes, there is that midlife hormonal shift weight gain that the majority of patients complain of. And this is not going to cause you to lose weight directly. Indirectly, we're resetting the system, we're balancing you out. So if all of the other lifestyle modifications are in place, then yes, you will be able to shed the weight that you've gained through the change. But to say hormone therapy is going to help you lose weight is not an appropriate statement to make to anybody because you're setting them up for failure because they're going to
mm,
come back and say, I didn't lose any weight, number one. And sometimes, as I'm sure everyone has experienced at one point or another, when you start hormone therapy, whether it's, being on birth control pills or hormone therapy, you might gain a little bit of weight. There may be a little bit of fluid retention that eventually subsides. I want patients to know this is not a way to lose the weight. This is something that's going to help balance out the hormones. And then we have to look at the metabolic side of things. And together we can fix all of that. But it's going to be a work in progress. I have patients come in every 6 to 8 weeks for follow ups and to see how are their symptoms? How are they feeling? Are they sleeping better? Is their mood better? Are they more tolerant or back to the way they used to be, less irritable, things like that? And again, 9 out of 10 times they come in, they're like, I'm going in the right direction. And that's
mhm,
what I want to hear. Are we
mm.
the right direction? Or are we worse? Or are we the same? And then based on that, I make adjustments. And eventually, I do repeat blood work. I do like to have the data points. I want to see numbers because I think the worst thing that we can do is have a woman on hormone therapy for disease prevention going forward, right? It's all about heart protection. It's all about protecting the bones to prevent osteopenia, osteoporosis. And imagine you're on a therapy and you think you're doing great. And then you check a bone density in a year, and lo and behold, we have osteopenia or we have worsening osteopenia leading to osteoporosis. That tells me the woman never really was either therapeutic in their levels or they weren't absorbing it well. So, to avoid that kind of a pitfall, I do check labs every 6 months or so at the beginning to optimize their levels and not just base it on symptoms as we used to do before. So, what I love about our field is it evolves. Every
Mhm.
see a new research study that comes out that makes sense. I'm like, okay, yeah, you know what? We do need to check levels because we can't just assume everybody absorbs the medication the same. We can't. Whether it's a patch or a cream or a gel or the Eva Mist or the ring, each person absorbs that estradiol differently. And so we need to look across the board and say, okay, what are they absorbing? How much are they absorbing? And is it working? A lot of times we don't think that there's a level, or we used to say, just kind of look at the patient's symptoms. And if they're feeling better, then they should be good. Yes, there is a lot of truth to that, but also what if they're not in that therapeutic window, which we know there is, it exists, there it's like where your estradiol level should be in the follicular phase when you were ovulate. So
Mhm.
somewhere between the 60s, 120, 150 picograms per ml, that's like where we want it to be in that range. If I have a woman who's on the estradiol patch and one of the higher doses, the zero point zero 0.05 or the 0.075 milligram, and she comes in and I check her levels and she's only at 60, I'm not really optimizing her levels. She may feel good, but I can make her feel better. And I can definitely make sure I'm protecting her heart, I'm protecting her bones, and providing her the best overall optimal care. And I think that's where the finesse of what we do comes into play. Giving hormones, you don't just write a prescription and say, see you later and see you in a year. That's the pitfall. It's really about noticing what's going on, checking the right labs at the right time. You don't want to be checking every 6 weeks. That's not going to be that's too much. So there is a just the right window where it's like every 3 to 6 months, kind of double check yourself and make sure it is what you think is happening with the patient. And that way you are giving them the, optimal care that they deserve.
Wow, I love that. I love that's really proper personalized care instead of just going into a doctor's office and just getting the standard
Mhm.
prescriptions based on symptoms, which is what I heard for such a long time. A doctor will evaluate you based on symptoms and then just start you on the lowest dose possible of hormone therapy. And then we'll see how it goes. That can be a pretty long journey, right? Of just seeing how it goes, of constantly coming back and forth to the doctor's office. And so I love how you talk about it and you look not only at the symptoms, not only listening to the woman and what she's coming in with, but also looking at her blood test and then checking on those bloods periodically. I love that. When we're talking about hormone therapy, let's take it down a couple of notches to the basics. Let's break down the pillars of hormone therapy for our listeners. So when you're talking to a woman about starting hormone therapy, what are the main pillars of hormone therapy that you're explaining to the woman that she can potentially start?
So, what I start with is we review their symptom questionnaire that I have them fill out. And I actually really ask them, what are the top 3 things that are your priority right now to address? Like, if you had 3 things to fix right away, what are those? And then we base it based on that. And a lot of times it's, not sleeping well, fatigue, no energy, and the moodiness. I think those are the big ones that
Mhm.
into the doctor's office where they're like, okay, I'm losing it. My friends are telling me I'm not being myself. My husband's upset with me. They catch themselves yelling at their young children and they're like, this is not me. And I don't want to be that mother. So it's those things that I take into account. And then we talk about the hormones that are going chaotic in their system right now. It's the estrogen, it's the progesterone, and it's the testosterone. I tell them these are the big three that are playing a role in your perimenopause, menopausal symptoms. And it's really each one does something different. So the estrogen, and I tell them there's the synthetics and the bioidentical. So estrogen, when we're talking estrogen, we're talking estradiol because that is the bioidentical, what your body naturally makes and what it recognizes. And that's what we want to replace. That's really the key element. Come along with that is a progesterone component. So those are the two big ones that I really start off with, depending again on each woman. Like there are those who are just, they're there, they understand what's happening, they want to address it, but they're not ready for everything. And then I have other women who want to come in and they're like, I want it all now. So from A to Z, and they want to go with it. And I'm okay. I will do either. I know my patients and I have an open discussion with them. So the estradiol is one component, the progesterone, I explain it to them as this is what's going to help you sleep. This is what's going to calm down your brain. It's kind of like the chill pill of hormones. It calms everything down. You're able to shut off the running list that you're making in your mind at night when you're trying to sleep at 2, 3 a.m. And then it also helps with people who develop anxiety out of nowhere. They're like, I've never had anxiety in my life, and now I'm anxious over everything. So those are the two that I discuss. And then the testosterone component, I bring it around. And I do explain that I'm more on the conservative side. So everything is more topical than injectable. I know about pellets. I use pellets on certain patients who've come to me on them given elsewhere, and they don't know how to manage them. So if I were to continue that woman on a pellet therapy, then I would go down that path with her, but I would really be watching her numbers closely and keeping her within the physiologic range of that testosterone. That way we don't end up having the irreversible side effects that can happen with too much testosterone. But most women, I will do topical testosterone. So, transdermals like either the cream or the androgel. And I would explain to her what it's for. It's really energy, it's libido, it's muscle mass, it's brain cognition, the brain fog that they have. So we go through all of it and I explain to them what to expect. Okay. With the estradiol, whichever version they use, the patch or the pill or the mist, I try and stay away from the pill just because if they have any kind of background history of blood clot disorders or anything like that, then we're better off staying with the transdermals. And I explain that to them because I have a story of a woman who struggled for years, saw multiple doctors, and she's a very well educated woman in the healthcare field herself. And because of a history of a blood clot at one point that was, just kind of happened after an accident. Nobody would give her hormone therapy, no form of it. And she was struggling. Like she was just not herself. She didn't feel well. She kept going around and would bring the studies to doctors and they would still dismiss her. It's not safe. You can't be on it. She came to me for a second opinion. I went through all of her paperwork. She had seen her hematologist, cleared. She does not have an underlying disorder for coagulation. She just had one episode, never happened again. I said, "You're a candidate." She said, "You're the first person ever to say that to me." I said, "You're definitely a candidate. I'm not going to give you oral estradiol, but I can give you transdermal, and we're going to see how you do on it." We're 6 months in, and basically her life has turned
Mm.
new person. She's like, "I don't know what to tell these other docs." I said, "Honestly, it's in the data. It's there. Everybody knows this. This is not news. This has been there. We have the data behind this. Just stay away from the oral. You can do transdermal. You are not somebody with an issue." So going forward, these are all the discussions that need to be had for a woman to walk out with that prescription and feel confident enough and safe enough to use it. Because you and I both know they're going to go out there and they're going to start using it. And then they're going to go to lunch with their friends and have discussion, right? And they're going to be like, "Look better and you look good and you're not cranky so much anymore. What are you doing differently?" And she's going to tell them, "I'm on hormone therapy." And
Mhm.
they'll turn around and scare her because of the lack of knowledge and the fear that's out there from the WHI study in 2002 and say, oh my goodness, you're going to get this and you're going to get that. And are you sure you know what you're doing? And so that is where knowledge is powered. That is where I feel I'm educating my patients enough to actually turn that conversation around and say, actually, that's not true. I spoke
Mm.
to her, she explained it all to me. And guess what happens, Gabriella? They all end up coming as patients because of the one individual, and they all trust her because 'cause they're friends, right? So
Yeah.
this is becoming more of a girls' lunch discussion, and it's spreading like wildfire, and my MO in the office is, "You know what? Let me fix the one I have here in front of me. I'm gonna help her, make her feel better, and get her back to where she was, if not better, and she is going to spread the word. I don't have to do anything." And this is where it's at for us practitioners on the front lines is let's get to as many people as we can because they will give the knowledge to their close friends and relatives. And that's how this is going to move forward, where the next generation of women are just going to be walking right into perimenopause and menopause without the struggles that we go through to get here.
Yeah. Yeah, but it takes that really solid what a patient-doctor relationship and really trusting
Mhm.
you as a doctor with the information that you're providing. That patient trusted you even though she had this history of a blood clot. She
Mhm.
trusted you that it was just this one piece of data that it wasn't the oral estradiol that was preventing her from being on hormone therapy, but it was that she just needed a different delivery system. And I think, yeah, because a lot of the doctors, as I understand, are not so well versed on the full, spectrum of hormone therapy, they will go to the most conservative options
Mhm.
and probably really follow the most conservative guidelines so closely and not take a step back and look at the bigger picture or other data point like you've done. Yeah, that's what I appreciate so much about you as a practitioner. I want to ask this one big question. So a woman has been on HRT for several months and she still feels awful. So opposite to that woman who went out to lunch with her friend, she feels terrible. You've put her on a standard dose, or maybe she's come to you on a very standard dose, whatever that is, maybe the lowest dose possible, but nothing's improved. What's your detective process when HRT doesn't seem to be working? And when a woman says this to you, what is the first thing you investigate? Is it dosing, delivery method, or something else entirely?
It's both of the above, actually. So what I do with her is I actually go through and make sure it's being used appropriately because sometimes when we can give the instructions and I even give them a handout of what we discussed. So they walk away like a folder full of like a plan of care for so and so. So for plan of care for Gabriella, you would walk out with that where we discuss estradiol patch, how to use it, and how much you're going to be taking. So they walk out with that. They have that in their hands. But even with all of those safeguards in place, a lot of times they come, oh, yeah, I use it once a week. I said, yeah, but that patch was meant to be used twice a week. So every 4 days. So maybe she wasn't, the patch runs out after a couple of days. There's not much left in there. So if you're using it once a week for a patch that was meant to be twice a week, that might be an issue. We're not getting enough in our system. Or if they forget, they come in and there's, not feeling well. And now they're bleeding all the time. And I ask them, have you been taking your progesterone on time? Oh, I did skip a few times here and there, or I was traveling to Europe and I didn't take it on time. Again, these are things that we can put out that fire quickly. On top of that, I would check serum levels to make sure are they being absorbed or not. And then I would definitely, if let's say they're taking it correctly and the levels are there, but they're on the lower end, then that's where we can fix that. We can just up the dosage of the patch or the gel and say, okay, now let's try it again and see how you do. But again, I think this is where it's critical to make sure women are coming in every 6 to 8 weeks to put out these fires because otherwise they're going to say to themselves, it didn't work that well for me. I'm not going to do it. It's not for me. And another thing that I have learned through the process, a lot of this is there are guidelines and there are tools that we have in place now. And we're getting more and more information and data every day. But it used to know the lowest dose for the shortest time period, which again, we've moved away from that. Hopefully, most of us, I hope we are all there. But the 0.025 dosage of that patch barely works for a patient. I can count on one hand the number of patients that have felt better on it. So I really skip that one and I go to the next lowest dose. And again, I will tell the patient more than likely this may not fix everything. Okay. But if they're hesitant or they're worried or they're scared or this or that, I will start there and I'll work them up. Majority of my patients are anywhere between the higher 3 doses of the estradiol patch. So I'm trying to get them up there because that's where I know the serum levels are going to be in that effective range where they're going to see the benefits in 5, 10 years from now, which is our end goal. Our end goal is longevity. Our end goal should be heart disease protection, bone disease prevention, right? And bone health. And so they don't end up with osteopenia, porosis, and end up needing surgery, hip surgery down the road. So that's our goal. And also dementia prevention. So my goal isn't to just fix the symptoms here and then take them off in a few years. My goal is the 10-year window of opportunity plus plus. Because my patients stay with me forever, usually. So I will be guiding them through the 10-year process. And at the 10-year mark, I'll be like, okay, we're going to talk about this year to year and decide how you're feeling on it. And I really don't take patients off. I have women now in their 70s coming to me and they're like, I went to my doctor. He wouldn't refill my prescription. He said, I'm off of it. And I said, what has changed? And nothing has changed. The woman feels amazing on her hormones. Her medical history hasn't changed. Nothing's different. I refilled it with no worries about it whatsoever. I said, "You're clear to go."
I love that. So just again, taking this very personalized approach, checking in every 6 to 8 weeks if things are feeling off, adjusting the dosage or the delivery method. Let's talk about progesterone for a little bit, because I know my personal experience with progesterone was that it made me feel really sleepy, really low in mood, almost depressed on some days. I wouldn't be compliant with it. So I would have that breakthrough bleeding. And I thought, oh my gosh, maybe this is not for me. But I needed the estrogen because I was diagnosed with osteopenia early on in my menopause journey. So I knew that I needed the estrogen. For dear life, I was gonna hang on to it to protect my bones, but I really had a hard time with the progesterone, and I couldn't get a straight answer from many doctors. I had to go from doctor to doctor to figure out what was the best option till finally one doctor told me, "You could just get an IUD," and I'm like, "What?"
Yeah.
What? It was like months that I was trying on a lower dose of progesterone. It wasn't doing. I was inserting it vaginally. I was trying different forms. Like, how long do you try to make the hormone work before switching gears? Like for example, progesterone. Is this very common? The progesterone sensitivity, and what do you do with it?
It is. It's some women are more sensitive than others, and we need to take that into consideration. Some people tell me I have a hangover effect, even on the 100 microgram dosage or milligram dosage, sorry, of the micronized progesterone. Okay, take it a little bit earlier in the night. That way, you don't have a hangover effect. So you have to be able to make tweaks to their regimen on an ongoing basis. Am I going to let them struggle too long with it? Absolutely not, especially if they're willing to try other forms. I will try transvaginal. Hey, put a vaginal progesterone in there and let's see how you do. And even if that still doesn't do it for them, then I will switch them to progesterone containing IUD, whether it's a Kyleena or a Mirena, for sure, to protect that endometrial lining. That way they can still continue on their estradiol treatment. But I don't like, and this is again part of the reason I see them so frequently, is to put out these fires left and right, because these are all reasons for noncompliance right there. And the worst is, let's say they love the patch, they continue on the patch, they don't take the progesterone, and now I have a bigger problem on my hands in 6 months where they have a thickened lining, they may have a polyp, and now we need to do a whole nother investigative procedure there. So to avoid those pitfalls, I switch. I'm very easy. I will put them on a progesterone containing birth control pill. I'll say, okay, you know what? Forget the micronized progesterone. You're going to go on a progesterone containing a birth control pill only for the progesterone side, and you're staying on your patch. And if
Mhm.
that fixes it for them, then I may have the opportunity to also offer them the progesterone containing IUD.
So how much time should we give the hormone therapy time to actually work?
Before switching gears or going to
Before switching gears, if we're just struggling with it or if it's causing us if we're not feeling any better, how much time should we give the hormone therapy time to work?
overall, the numbers have shown, like, you need to give it a good 2 to 3 months to see maximum effect of all of them, of the estradiol and the progesterone together. But it really depends on the patient and what they're struggling with. If it's affecting they're sleepy all day the next day and they can't even function to take care of their family or go to work, I need to address that before the 3-month mark. Okay. So that patient, I would try and have them take it earlier. Sometimes I have them do it every other night just to see what, and maybe build up their system to it so then they don't have the hangover effect. Others have said, what if I switch to a compounded version of progesterone? I'll do that, but I'll explain to them again, compounding is not FDA approved because we never know how much you're getting each time. It could be a different dosage. But again, I have a couple of patients who do really well on the compounded progesterone because they can give different doses. They can give 75. They can give 150 rather than 200. So we have to play around with it. If it's not that bad of a symptom or effect that it's having, I will give it the 2 to 3 months to see really how their body's reacting. But if it is something that's affecting their daily life, then I'm not going to wait 3 months. I will definitely
Mm.
have them in within 4 to 6 weeks and say, what's going on? Let's break it down and see how we can make it better.
Great. Thank you so much for that. So, just to summarize this particular part of this conversation, I know I've heard from women who said, my doctor doesn't want to measure my estradiol levels. You believe in measuring estradiol levels because I think many doctors are of the older thinking of let's just monitor your symptoms and just see how you feel. But you're saying that optimal ranges are well established in the research, but doctors are still practicing medicine based on sort of the outdated Women's Health Initiative fears. Is that right?
100%. Yeah, we're having a lot of that. And in this realm, with a lot of the women doctors in the realm of menopause and leading the charge with all of this, that's where we're getting the new information. So we're all coming along with it. It's just you're going to have people that slowly will come on board with it. And this is why we're all using our platforms and doing these discussions is to get this information out there.
Mm.
This is not anecdotal. This is published research that we have. People are doing Substacks now, which I was like, what is a Substack? But it took me a minute and I understood. It's just going into more depth and really explaining what we mean. We're not just talking to talk. We're really here to give the information and open up and have people think outside the box because we're very regimented as physicians, as healthcare providers to be within guidelines. And I'm all about guidelines. I've been like that all my life. But you need to be able to kind of think outside of it a little bit without obviously harming the patient, but realize, hey, if we were not to stick to guidelines, nobody would be on testosterone because technically it's not FDA approved for use in women. But we use it very cautiously, but we know the benefits it has for women. We just use the male version at a female dosage. Okay. So why can't we do that with everything else? That's where the checking the levels comes into play. You're literally checking a lab level to make sure you're in that therapeutic range. That is a step. We know there's data to show where it's going to help the bone. There's data to show where it's cardioprotective. And if you're below those levels, you're helping with vasomotor symptoms, but that may be the only thing you're really doing.
So, do you think many women are actually being undertreated with hormones? The hormones actually aren't doing anything?
Yeah, they can be. Listen, I have a woman come to me and she's on a 0.025 dose patch. I feel terrible for them because I know I didn't give it to her. She was given that by another practitioner who since maybe has retired and this is really all she had. So she just held on to it and has been using it, religiously. And I was like, Now what do I do? And I check her levels and I show her, I said, this is you on this dosage. Unfortunately, it's not. It's basically, I would hate to give somebody a false sense of security. So you think you're doing what you're supposed to be doing. And then you look at the data and you didn't protect your bones. Now you have osteopenia, or God forbid, you even have osteoporosis. And imagine you've been on this 0.025 patch for 5 years. So we need to really hone in on women and look at them one by one. No two are the same. No two women's symptoms are the same, and their presentations are completely different. So why would they all be on the same doses or the same regimens? Maybe they're all on a patch and a pill, but maybe there are other variations to it. So we need to take that all into consideration.
And so when the numbers look good on paper, but the woman still feels terrible, what other factors would you investigate? How do you differentiate between this HRT formulation isn't right for you versus you need time to adjust versus perhaps maybe this is a lifestyle or stress issue masquerading as a hormone problem? That's
And
also an issue, right?
yeah, that's the other part of it is what if we're just harping on the hormones, right? And what if they're optimized? What if her levels are great, but she still doesn't feel well? Maybe there's something going on at home. Maybe there are life stressors. Maybe she's having an issue with her partner. Maybe she's losing her job. Those are the things that need to be teased out. But how are you going to do that in a 5-minute visit? You can't. So we need to really be in tune with our patients and sit and break it down with her and say, okay, how again, the questionnaires I have them fill out at the beginning, I go back to that. I'm like, "So this is what we started with, and tell me what's better, what isn't." And then from there, I will go through and say, "Okay, what else is happening?" And most of the time, you can get it little by little out of them. So what if they're just not sleeping well and they're just exhausted? What if it's an iron deficiency problem that we never uncovered? And now I send her to the hematologist, she gets iron infusions, and she feels like another person. So we can't really tunnel vision to just hormones, hormones, hormones. You have to look at the overall picture. I have women on certain supplements. I don't have a ton of them. I have a very small subset that I have them try. And I put them on magnesium 3 and 8 throughout the day, and they come back and they're like, that brain fog thing is gone. My memory's back. I feel amazing. That was a magnesium supplement. I didn't put her on anything else. Okay. But that's in conjunction with her hormones. So it's all working together. But again, we need to have those discussions with our patients and have, like, I like how they call it the toolbox. You need to have a toolbox of things. It's not just one or two things that you pull out of that toolbox. It's a myriad of things. It's supplements, it's talking to the right people, it's discussing health, sexual wellness, intimacy. These are taboos that are still not discussed easily. I can assure you, I ask patients about their intimacy and they're like, that's fine. No, what does that mean? They're like, well, I mean, I do what I need to do. And they go down that path. And I just sit down and I'm like, and now we're going to get into that. That is a
Mhm.
whole nother hour long
That's
discussion.
another conversation, yeah. So what do you do with that? How let's talk about that. So the symptoms of either low libido or vaginal dryness, that's a huge conversation. Do you just address it via the systemic HRT, the estradiol, the progesterone, and wait and see if her libido or her vaginal dryness gets better, or do you take a more targeted approach?
I'm actually probably one of the only Addyi providers down here in South Florida. I'm a big proponent for Addyi because I've seen what it can do in women. I've seen it with my own 2 eyes where they come back and they're like, "What happened?" Like, "What?" It's listen, we know the neurochemicals in the brain are affected through perimenopause and menopause, and that's why it becomes kind of like, that hypoactive sexual desire disorder is a real thing where it's not even in their forefront, Gabriella. They don't even think about it. It's like, ugh, if you had the to-do list to do, it wouldn't even make the to-do list. That's
Mhm.
how bad it can be and how severe I've seen it turn. And so I do the hormonal route. I do talk about them about sexual health and well-being. I refer them honestly to your podcast and to Sex with Emily. I'm like, have you heard about them? No. I said, I need you to listen to this and I need you to understand sexual health is a part of your health and well-being as a woman. We are not done with that side of things either when we hit 50 or 51. Who says that? Like, it's part of just being you. It's part of being intimate with your husband or your partner. Okay. So we need to hone that in. We need to enjoy it and not just dismiss it or make it a chore that needs to be done and a box checked off. So it's a lot of handholding with that. It's a lot of talking about it. And then I do introduce Addyi into the discussion, and they're taken back by it. They're like, "What do you mean?" I said, "It means you actually start thinking about being intimate with your husband." But, again, it's a hypoactive sexual desire disorder. It's orgasm problems. It's also vaginal dryness. It could be that as well. So what part of it is it that we're really dealing with? And
So
I find
let's talk about that. What part are we really dealing with? So you've mentioned Addyi a couple of times, and why don't we just pause there and explain to our listeners what is hypoactive sexual desire disorder and what is Addyi and how does Addyi help with that?
a hypoactive sexual desire disorder is where basically the inhibitory neurochemicals in the brain are overpowering the excitatory ones, right? So excitatory hormones, neurotransmitters in the brain gives you that rush, like that energy, that desire to want your partner, to be intimate with them. So dopamine, norepinephrine. Now in perimenopause and menopause, you have a shift. So you have the more like serotonin, which makes you sleepy. Those are all elevated. So there's an imbalance in the brain chemically that causes you to just not have the desire or the you just don't you're not looking for it. It's
Hmm.
just not there. The drive isn't there. So Addyi fixes that imbalance, right? It takes the neurochemical, it's a neurochemical modulator basically. And now all of a sudden, over time, it is the pink pill, like in conjunction to the blue pill, right?
Or
And
Viagra. Yeah, the Viagra blue pill.
so some people call the Viagra for women, but it doesn't really work like Viagra, where it's an on-demand situation. It takes a while to kick in because it needs to change neurochemical pathways. So because of that, it can take 2 to 3 months to see a difference of taking a pill every night. So again, the precedence has to be set with patients where they understand this is not an overnight situation. This is going to build up in your system, and eventually you are going to notice the benefits of it. And that's the way I've noticed it with my group of patients is they start having vivid sexual dreams. They're like, wow, I'm having these dreams. I'm not really sure what to do with that. I said, it's okay. Your body's, kind of getting back to where it needs to be. And so in my time of using Addyi, I've had patient come to me within 2 months and see the benefits, and she was like, "Wow, this is working, I need more." And I've had one take as long as 5 months to see the
Mhm.
benefit, and her response, her remark was when she came in was that her desire has come back better than even when she was in her 30s and 20s.
Mhm.
Partner is just astounded and can barely keep up with her. This is where it's at for this medication that is FDA approved, that has been around for over 10 years, and we have studies and research behind it. Yet most women don't even know it exists.
And so how would you assess whether a patient needed Addyi and whether or not she needed testosterone? Because doesn't testosterone also address hypoactive sexual desire disorder?
It does, and each one is a little bit different. So I start depending on how bad it is, again, it's a patient to patient situation. I will start them on the testosterone to see if they have response to it. And if within a short time frame they come back, they're like, I have more energy and I feel better, but the libido's still not there, then I add in the Addyi component.
Mhm.
I have other patients who are like, the libido's gone. I think my husband's going to divorce me. Something has to happen. And that's where I'd rather have them on Addyi sooner rather than later because it
Mhm.
does a little bit to work. So I
Mhm.
would those differentiations for that patients.
Okay, great. Thank you so much for explaining that. And then where does vaginal estrogen come in the picture? When do you wait until the systemic estrogen, the estrogen and the progesterone, or maybe the testosterone take effect in the body and then add vaginal estrogen? Or is it something that you see as preventative and you add from the get go?
Honestly, I think, again, evolving over the years of doing midlife care for women, everybody should be on vaginal estrogen, honestly, like starting in their late 40s, or as soon as they have a symptom, it's a preventative measure going forward. And when I see patients come back, I can even in my own little practice, right? I have seen where they come in and I have them on estradiol patch and progesterone. And then I'm like, why didn't I start her on vaginal estrogen? What was I thinking? And now going forward, everyone's on all of them. Like they come in for their follow up, they're on estradiol patch, estradiol cream, progesterone, and testosterone. Like it's already there. So I've even shifted and changed what I do for my patients and how I counsel them. So majority are on vaginal estradiol already. To differentiate, and these are the questions that need to be asked, is when you do have sex with your partner, is it painful? Do you have to use lubricants? Or do you feel sore afterwards? If the answer to any of that is yes, then there is a vaginal atrophy aspect to it as well. So it's not just desire, it's also discomfort. And that plays into the lack of desire because now there's a negative feedback. Where if you're going to be intimate, it's going to hurt. So who wants to do that again? So it perpetuates the lack of desire. Now, then I ask them, if it didn't hurt, would you have desire? And they're like, oh, well, then yeah, I would be wanting to have, intercourse with my husband all day long. So that's more of a pain atrophy problem. And that patient, I would just really start her aggressively on the vaginal estradiol and then see how she does. In terms of using the estradiol cream along with the patch or the gel or the mist, I tell patients they work together. You're not overdosing because we all know vaginal estrogen works locally. It doesn't get absorbed significantly into the bloodstream to affect your serum levels. Hence, it is a safe option for women to be on both of them. And a lot of times I've noticed the transdermal isn't enough to help with the vaginal atrophy going on below. And so they're on both from the get-go.
Okay, excellent. Wow. So you really stay on top of all of those pillars, the estrogen, the systemic estrogen, the progesterone, the testosterone, and the vaginal estrogen. Those are incredible key pillars of hormone therapy. Let's shift it now to the metabolic connections. I know you focus a lot in your practice on metabolic optimization. How do hormones and metabolism intersect during menopause? I know that's a huge question. And why is this connection so crucial for overall health and success with hormone therapy?
So, a lot of women, when they're going through hormonal shifts and changes in midlife, it causes an inflammatory response internally as well. And that inflammation can, in some women, lead to insulin resistance, weight gain. The adipose tissue, the weight gain that they obtain is more visceral fat, not adipose, like subcutaneous fat. And we all know that visceral fat is the more dangerous one. It's fat basically wrapped around your organs internally. So we need to address that appropriately. It's not a one-sided equation. It's a hormonal side, it's a metabolic side, they intersect. So you need to address them both in order for the patient to be successful going forward. And I have patients who have that 10, 15-pound weight gain throughout perimenopause. And once we optimize the hormonal side of it, then automatically internally the inflammation subsides and now their insulin resistance improves on itself. And so they're able to shed the weight. I have others who are not so fortunate. And so they have to work a little bit harder at it. And this is where I think a lot of this obesity medicine component is coming into play. And that's why we need to be up to date with it as well as healthcare providers for women. Because the GLP-1s, I don't want them to get a bad rap here. There's a place for them to be used safely under the monitoring of a healthcare provider who is well versed in it. Sometimes they're endocrinologists, other times they're primary care physicians, but I don't want them to get it at a med spa or something like that. I think it's better under our supervision. That way, we're monitoring and minimizing side effects. They're really, if you use the GLP-1s appropriately for as long as they need it, some will need it going forward because what are we doing here again? We're trying to prevent disease happening. And a lot of the patients who never had a diabetes or a glucose problem now start becoming pre-diabetic. So that's all, again, part of this whole shift that's happening internally. And a GLP-1 can help address that shift going forward, prevent them from getting diabetes, which then prevents them from getting heart disease, and they can live healthier longer going forward. And the question always comes, how long do I have to be on this? Can I microdose this? And these are all questions that are really, again, just things that they hear, I think, out there. And there is no real thing as microdosing. It's using the smallest dose. That's what that is. And there was an endocrinologist who said, if you're on a medication and it makes you feel well, why would you come off of it? You have to take that into account and consider, yeah, you know what, you're right. Like she was on it. She lost the weight. She feels great. Maybe there is a role for this to be part of her regimen going forward. Okay. But there are others who are like, I only want to use it to lose the weight and then see how I do. I'm okay with that too. Because why? I'm monitoring their lifestyle. I'm monitoring the diet, the nutrition, the exercise regimen. And as long as all of that is in place, and then they use that to lose the weight and get to the other side, then we watch. We wait and see, how are you doing? We check her levels and everything. And if she's doing well, I don't see a need to continue, but there is a place. And again, it has to be done on an individualized situation.
Hmm. Okay, great. Thank you so much. I haven't really talked about GLP-1s here on the podcast, but it's definitely a topic that's of growing interest. I've had requests for that, so I'm so glad that we've touched on it, and potentially would love to have you back to take a deep dive on that. Going back to HRT, so HRT or MHT, menopause hormone therapy. We know that it addresses all the symptoms we've talked about: mood, sleep, anxiety, libido, but you've also mentioned lifestyle. The menopause hormone therapy itself isn't a magic bullet. It works best with lifestyle changes. So what lifestyle factors have you seen give the biggest bang for the buck when with HRT success in your experience?
So, in terms of how I look at all of that, honestly, is I've delved really into the nutritional component side of this because we were again raised on the low fat, low carb diet situation. And I don't really like the word diet because we're not dieting. This is how you have to live. So, it has to be something that's sustainable. And there are a lot of really good programs out there. So, like the Mediterranean diet, if you look at it, it's delicious, it's healthy, and it's fresh. So, what I tell patients is, I want you to eat everything. I want you to eat carbohydrates. I want you to eat bread. I want you to eat fruits, vegetables. I don't want you to take anything out. But what we're going to do is we're going to do it in moderation. We're going to add the protein in. You need all the different protein. You need your vitamins. You need all of your greens and things like that throughout the day. And I don't want you to, go too long without eating. I prefer the 3 meals and snacking throughout the day because that is what I've seen work for women going forward. Now, the other lifestyle thing I think is important is exercise. It's
Mm.
critical. Movement daily has to be happening, whether you're walking with a vest, whether you're, training with weights, dancing, that's cardio, that's amazing. These are the things that need to be happening on a daily basis, and we need to have a regimen for it. So I really look at the woman and see, what have you done? What is your exercise regimen? And if they just go to work and do what they need to do, then I'm like, okay, then you're going to have to walk at least. Let's just start with the walking 4 or 5 days a week. And now we have the number of steps. Let's just try and get over 10,000 steps a day. It's harder than people think because I'm at a job that I'm walking around all day long and I thought I was getting in my steps easily. I was wrong. I was so under the number of steps that we are talking about that I was like, okay, this is a lot harder than we think. So we really need to focus on it. The weighted vest is a great option for a lot of women who've never really been to the gym. They haven't stepped foot in a gym in like 10, 15 years. I cannot put them into a gym with a CrossFit type of workout. It's not going to work. They're going to injure themselves and then they're going to set themselves back. Again, it has to be done on a very individualized basis. And I give them all of these tools to say, okay, this is what you're going to do. And I hold them accountable for it.
Mhm.
I'm like, okay, did you walk? Yes, I did. How many times a week? And how much did you do? And they all come back, hey, you know what? I bought the weighted vest. It's really good. And I put it on and now I'm putting in more weights and it's helping. And they feel empowered. They feel, okay, you know what? I'm getting control of my life. That helps them kind of stick with it. That is a positive feedback loop here because now you've empowered them to do all of these little modifications at home that little by little over time will build up. and give them the long-term effects that they're looking for. But it's all in the tweaking of things and being able to understand where your patient's coming from and giving them the right guidance, basically. Not everyone's, okay, now go to the gym and lift weights 3 times a week, and that's not gonna work. There needs to be cardio as well, but again, not change the balance of it. Change the balance of cardio to weight training, and that's where you're going to build strength. That's gonna help keep you strong with your bone and keep the muscle building, and that muscle building is going to help with your metabolism going forward as well.
Amazing. So you definitely see improvement in women's symptoms when they incorporate those lifestyle factors.
100%. Like, they come back and they tell me, "I didn't realize how much I was missing by not moving every day."
Mhm.
We've become sedentary. Unfortunately, it's we work from home. Everything is at our beck and call, so you're not really moving as much as you think you are. And to put aside the time to go out and walk, it's changing because it's clearing your mind too. It's good for your cognition and just kind of being out in the sunlight, rather than under, like, false lights and things like that. It improves mood. We know this has been shown over and over again. So it's really interesting to see women changing and learning and evolving and kind of feeling better about themselves.
I love that. I love that. Yeah, it's so, so important to incorporate those lifestyle nutrition and movement modalities. What about the mental and emotional aspects of menopause? I've found from my personal experience that hormones can support my body, but often don't bypass the need for deeper emotional healing. The years and years of like suppressing our needs, suppressing our emotions. How do you address the mental and emotional aspects of menopause alongside hormone therapy? Or how do you recommend women do that?
Women, we put ourselves last all the time. We're moms, we're wives, we're doctors, we're healthcare providers. We do everything for everyone else, but when do we take time for us? And this is critical, especially in this time frame, in the midlife. It's like you kind of become a different version of yourself because you learn to say no, to set boundaries, and do what serves you. Because if you can optimize yourself and be the best version of you, then there's more that you can give and do for people. But if we're running on empty, you can barely do anything else. So, what I tell women going through this midlife shift can really play with the mental psyche. Like, it can really, you're not reproductive anymore, you're gaining weight, you don't feel like yourself, you have no energy, you have no motivation. Some people kind of become, kind of introverts and they don't want to socialize. And it can really lead to deep, dark places where they go into full blown depression. And that's kind of where they end up with a primary care physician who then puts them on antidepressants and anti anxiety medications and sleep medications. And we need to understand that, explain it to the patient, and tell them, hey, it's okay. You're not alone. Everyone goes through this, and some are more than others. And we know that women who had a history of postpartum depression or baby blues, or women who have a history of PMDD or mood disorders, anxiety, ADHD, those symptoms are going to be exaggerated as they go through their hormonal shifts in perimenopause and menopause, and it may worsen. So we really need to be in tune and kind of help them, guide them through this, and make sure that they have a therapist or somebody that they're speaking with who understands this and says, okay, let's see if we can help with the hormone changes and let's stabilize that and then see how you feel. And at that point, maybe we want to consider adding other medications in, but I wouldn't just jump to that. And I need them to understand it. And once they understand, then they're okay with it. And they're like, okay, so I am not losing my mind. This is just part of all of this. And it really takes them by surprise. Like, are you kidding? It can affect everything to this extent. And I tell them, yes. I've seen my own eyes. I've seen women come in sobbing. And again, these are women I've known for 20 plus years. And I know her persona, and she's yelling at the staff and just being a different person. I'm like, it's okay, guys. let's have her in. Let me talk to her. And they're like, what's, I'm like, yeah, she's not feeling well because her hormones are out of control and she doesn't know what's happening to herself. So once we get them on that routine of every 6 to 8 weeks of coming in and they're, oh my gosh, I'm so they apologize to my staff and like, I'm really sorry. That wasn't me. And again, it's learning, it's knowing patients and your women and understanding what's going on with them. And that's the relationship that we built. And that's where they feel seen because we know what's going on with them. Like, I know we've been through it. And if not personally, I've been through it with them where I'm like, oh boy, that's not her. That is not her. She doesn't normally behave this way. Something must be going on. So there is a big mental toll that it takes on women. And unless we get them to be aware of it, it
Mhm.
to help a lot of patients. And I know you were at the Empower event where you saw there was a journaling expert that we brought, and that little aspect of self-care of writing things down, taking 10 minutes to yourself in the early morning before, everybody wakes up, that can change your outlook on things and how you approach your day. So it's little tweaks like that that need to be incorporated.
Yeah, so just being aware of the importance of taking time to process feelings and emotions. Yes, the hormone therapy may help take the edge off some of the emotional and mental toll, but there's still work to be done, especially if you've had these previous conditions like you mentioned, PMDD or ADHD or some sort of sexual abuse. I know from women that I've heard, or early childhood adverse events that just haven't been processed. We haven't taken the time to process some of these things that have happened in our lives because we've been so busy. We've been doing all the things and being all the things for everyone else around us. So I love that you mentioned journaling and seeing a therapist. That's so important because, yeah, like we said, menopause hormone therapy is great for taking the edge off of those feelings and bringing your hormones up to a certain level of, feeling like yourself again, but there's still work to be done, especially if you're still not feeling like yourself.
And I think there's one more caveat to or another perspective, which is your partner's perspective, the male
Mhm,
perspective.
mhm, mhm.
They're clueless as to what's going on, and it's not their fault. Number 1, we as women didn't know what was happening to us, and how do we think our counterpart is experiencing this? And if you really sit and speak with some husbands and partners, they'll tell you they lost their wife. Like, they're terrified. They don't know what's going on with her. They don't know how to approach her. They feel like they're walking on eggshells around her all the time. And so we need to address that side of the equation as well because they're the ones getting the brunt of all of everything emotionally going on with women. And that's where I think either the relationship, depending on the strength of it previous to all of this, it's going to withstand or not. Is them being aware of what's happening and realizing it's really not her fault per se. It's just her body shifting and changing, giving her the time and the grace to work through it and being supportive of it. Not saying you must not be attracted to me anymore and you don't love me anymore. And this that is counterproductive. That's not going to help. She feels bad enough herself. So they need to be more supportive, not like antagonistic. You need to educate the men. And we're getting,
Yes, yes.
I've seen things coming up and I'm like, the men's guide. I'm like, oh, yes, I love that. Talk about that. But it's just a two-sided
Yeah,
conversation.
we need to bring them into the conversation. Absolutely. Thank you so much. I feel like you've given us a very holistic perspective of how to address our health in midlife and really looking at the whole woman, not just the hormonal picture. There's so many pieces to our midlife health puzzle. It really takes a doctor who, like you, who takes time to listen, who takes time to really personalize the approach to how each woman feels and wants to live her life. And I feel like you really address all of those key pieces, right? Her hormones, her lifestyle, her mental, emotional health. Those are all so important. So thank you so much. For a woman who's listening, who perhaps has been struggling with hormone therapy that isn't working, or who feels defeated by by the healthcare system or her doctor who doesn't listen, what would you want her to know? What would you tell her?
I would tell her to not give up just yet. There's a lot of doctors out there willing to help, to reach out to one. I have people DM me all the time. Can I help everybody? No, but I can find someone that can help them. So, depending on where they live, we have resources. We have a huge community, a network of healthcare providers that are well versed in this field who are willing to help. We have telehealth people, we have telehealth companies. So, I would tell them to reach out to myself, to you, through all of these, networks that we have going on social media and through podcasts, and get some help if they need more to do, or maybe go to the Menopause Society webpage or even Mary Claire's webpage on the Pause Life, where she will break it down by zip code where the healthcare providers are that are well versed. And Mary Claire, actually, hers are more vetted, I think. They're more subspecialized. So she'll really go above and beyond to find people that she promotes and says, yes, go to this individual. They will give you the help that you need. And those are some resources that are available online that can really help women not give up on themselves.
And what gives you the most hope about the future of menopause care and women getting the personalized and optimized care they truly deserve?
The movement has begun, and it's a huge wave coming, and women are becoming more educated about their health, and they're taking ownership of that. And so they're not being pushed around anymore. So I
Mhm.
love that aspect of it, that they're going in empowered, and they come in and they're like, I did the questionnaire, these are my issues, and this is what I need. That's number one. And I think the other side of it is the newer healthcare providers that are coming out of training are better trained at this than we were. And going forward, I'm hoping that the programs are changing where they're being taught menopause care, and more time is being spent on it at the residency level. And that way, when they come out, they're ready for it. And we're getting it into more fields. So it's not just OB-GYNs that need to do this. It's honestly family practitioners, primary care providers. They all need to be in on this conversation. That way, we can address more women and take care of everyone out there who.
Well, I'm so glad that I met you and that you came on to the show. And yeah, you're really proof of what's possible, right? As a women's healthcare provider, right? You didn't have any former training, but you went in and did all the work. And now you're this amazing menopause care provider who not only just provides basic menopause care, but you optimize and personalize your care to such an extent that you're really getting women to feel like the best versions of themselves. And I love that. Tell us, how can we find you and get access to the incredible resources and care that you have to offer?
The best way to find me is on social media on my Instagram page, which is just my name, Dr. Jila Senemar. And then, we have a podcast and you can listen in more on all of that as well. But
What is
everything,
the name of your podcast?
it's called Her Time, Her Health with Dr. Jila. It's on Apple, Spotify, all the major platforms. And we just discuss all of these things that we talk about on a weekly basis. And we bring on amazing guests. And so I'm sure we'll have you on there soon, Gabriella.
Oh, thank you. And do you do telehealth?
I'm in the process of getting that all set up as well. Because said, I think we just need to help as many women as possible. So yes, that will be coming in the next few months.
Or people can go see you in Miami? Wonderful. Before we wrap up today, I want to leave you with some actionable steps you can take right now to advocate for better hormone care. Because here's the truth: you are the CEO of your body and you deserve so much better than being told, just see how you feel. First, start tracking your symptoms. Write down what you're experiencing: brain fog, sleep issues, mood changes, energy crashes. Be specific. This gives you concrete data when talking to your doctor. Second, research qualified menopause providers in your area. Look for doctors who specialize in hormone optimization, not just basic hormone replacement. The North American Menopause Society has a provider's directory, as does Dr. Mary Claire Haber, all linked in the show notes. Third, Call and ask the provider if they do blood tests and if you can have a complete hormone panel done, which includes estradiol, progesterone, testosterone, and FSH before your appointment so you can discuss it when you see them. You want to know what your estradiol levels are and ask if they're within the 65 to 150 picograms per milliliter range we discussed today. And if not, can you adjust the dose of your hormone treatment? Fourth, prepare questions for your medical consultations. Come armed with specific symptoms, concerns, and questions about monitoring your levels. Don't let anyone dismiss your experience. And get a second opinion if you need one. Fifth, consider lifestyle modifications that support hormonal health. And we talked about this with Dr. Jila today. Your nutrition, movement, stress management, and sleep all impact how well your hormones work. And if you feel you're struggling with your mental health, find a therapist or ask for a referral. Remember, hormones can support your body, but don't bypass the need for emotional healing. And finally, join supportive communities of other midlife women. You're not alone in this journey, and learning from others who've navigated menopause hormone therapy can be incredibly empowering. The bottom line, you have the right to receive healthcare based on current research, not outdated fears from decades-old studies. You deserve a doctor who focuses on helping you thrive, not just managing symptoms with the bare minimum. Your hormone health is important. Your blood levels are important, and you absolutely have the right to understand what truly optimal looks like for your body. You deserve to feel your absolute best, and that starts with demanding the care you deserve. Want to help me spread more pleasure in the world? Please subscribe, rate, and review this episode, and share it with a friend or someone you love. This helps this information get into the hands of more women who truly need this information. Thank you so much for joining me for this episode of Pleasure in the Pause. Remember, your pleasure matters.